I will show you a case. His name is Roberto. I have bad news. He's also a professor of history. So there must be something going on in the academia. So he was born in Buenos Aires. He lives in downtown Barcelona with his male partner. They have been together for more than 20 years. They love each other, but they have an open relationship. So they often travel to Southeast Asia, but the last trip was 2 years ago. Roberto smokes 15 cigarettes a day since he was 14 years old, up to 25 cigarettes a day when he has exams. And he has tried to quit twice, but unsuccessfully in the last time 10 years ago. He occasionally drinks malt whiskey after lunch, so he knows what he's doing. He's admitted to our hospital's emergency department for severe pain and functional impotence in the left lower extremity after an accidental fall while he was walking down Passeig da Gracia. So what is the most likely diagnosis? If you see, I will go quickly, but we have several options. So one option is left knee fracture, left hip fracture, left ankle fracture, left mid-tibial fracture, and the fifth one is, come on, he's just pretending, right? So,
it's too much wrong.
It's too much wrong, yeah. So, of course, he has a left transcervical femoral neck fracture that you can see here. So, I will quickly go through, there are a number of risk factors. The first one is decreased bone mineral density, decreased muscle mass, also sarcopenia is an important factor. Sex, bone fractures happen in 70% in women. Falls, any reason which can make you fall, even the malt whiskey. So medications like cortisone and some antiretrovirals, nutrition, eating disorders, age. So this happens mostly in more than 70 years old people. Alcohol, tobacco, endocrine disorders, low physical activity, and stroke, Parkinson's disease, and other neurologic diseases. So he is admitted to trauma, and he gets surgical repairment, right? So let's not make that story longer. But while he's in trauma, he has a favorable surgical evolution. But during hospital admission, a first-year resident actually notes the following lesions in the left arm and mouth that had become unnoticed, right? And then he calls his attendant, they come, and they say, okay, this looks like a Kaposi's sarcoma, and the skin biopsy confirms a Kaposi's sarcoma. Then they decide to do an HIV serology, which turns positive. The viral load is 125,000. CD4 counts are 214 with 14%. His HLA-B57 is negative, has a wild-type genotype. He has been previously exposed to hepatitis A, but he has HBV and HCV negative. He has syphilis. And also he has high total cholesterol and LDL cholesterol. And they go through a CT scan, and it turns out that the CT scan is normal. There's nothing really. Well, there are a number of treatment considerations for KS, but what you can see here is probably you can say that this patient has a minimal non-progressive mucocutaneous disease, or at least this gives you some room to start treatment first and then see what happens with this KS. Of course, there would be discussions, and some people would be more aggressive, but let's say that they prefer to start treatment immediately, and they do this because we have all this data from the START trial going on. So they decide at that time to start with alvitegravir, covicistat, tenofovir, and FTC. And during the first 6 months, viral load declines quickly, CD4 counts increase, KS lesions resolve, and then he goes into rehab and physiotherapy. Everything is going fine, but he still has pain in the left leg, and he requires NSAIDs. He's back home, back to classes, ends up walking with a cane, but still smokes 20 cigarettes per day. So he complains, then he comes to your consult, and he complains of epigastric pain and still needs NSAID. So what can you do? You have different options. So first one is give him omeprazole with no changes in his antiretroviral regimen. Remember that he's on alvitegravir, covicistat, and Truvada. The second one is giving omeprazole with minimum 2 hours after or 6 hours before his ART. Give him antacids with no changes in antiretroviral regimen. Change his treatment to the Runavir plus Truvada, and then give him omeprazole, or just tell him to be tough and stop moaning. So because we don't have much time, I will not extend some of these questions. So the issues that you can probably hit on, if you need to, this is a very frequent consult that you have in the clinic. So We need to worry about antacids and integrase inhibitors here, and these are the ones that need to be separated. And anything I say wrong, please, Marta, correct me. But you can actually provide omeprazole to this guy with no problem. If he was receiving rilpivirine or atazanavir, then you would have to be more careful. The second point I want to make is that in principle, you should not worry much about the non-opioid analgesics, but please keep in mind that if your patients are taking efavirenz or etravirine, some of these levels of these non-opioid analgesics can actually be high, so you don't need to start. So it is recommended. The clinical significance of this interaction is uncertain, but it's recommended to start at lower doses, and that's it. And please make sure that if you have to go on to opioid analgesics, then you really need to be careful, and you really, in practice, you need to look at the Liverpool app. And in this case, because there could be some significant changes in levels of these opioid analgesics, which in most cases they are not clinically significant, but also with albuterol covisistat. I'm okay? Yeah. So you put him on omeprazole, so he gets better, and you have 2-year follow-up. His viral load remains less than 50. His CD4 counts have increased to 550. However, he still has high total cholesterol. I don't know why you forgot about total cholesterol, but that's fine. It serves as a case. So he still smokes 10 cigarettes per day. His C-reactive protein is 35, and his BMI index is 29. So what single medical intervention will have the greatest impact on his life expectancy, right? What's this thing? So you have intensify diet and start on statins, initiate AC antagonists, quit smoking, treat him with sevelamer, and I do research on the microbiome, so you could try to modify his microbiome. The short answer is smoking kills. And it is completely is often overlooked in our clinics. Even in my patients, I have to admit that I probably don't do enough. It is also very difficult and to do, but see, this is the most important. So often we care about PCRs and markers and stuff like that, and microbiome and things like this, but smoking accounts for more than 6.5 years of life expectancy losses, both in men and women, a little bit less in younger men and women, but it's the single most important thing. This study is from the group by Rochelle Walensky. I think I cited it in the previous slide. I'm sorry for not citing it in this one. But you can see that if you quit smoking early, then these loss in life expectancy can be recovered. So there's a huge, it's really important that we put that in as a top priority. They summarize that smoking cessation by 10-25% of HIV-infected smokers could save approximately between 100 and 250 years of life. HIV-infected US smokers aged 40 years lost more than 6 years of life expectancy from smoking, which is probably outweighs the loss from HIV infection itself, and smoking cessation should become a priority in treatment programs. And because you are such a good physician, then you convince him, and also a magician, and then he actually quits smoking. But nevertheless, he still has high cholesterol, LDL, HDL. His BMI index, now because he does not smoke, he has started to eat a little bit more. His BMI index went up to 32. And he starts to develop criteria for type 2 diabetes. So in addition to diet and exercise, which statin would be preferable if you would like to keep him in the same antiretroviral therapy? So we have different options. We have simvastatin, the most famous one, the oldest one, the cheapest one. And this is the one that when we prescribe some other statin, and the patient, at least in Spain, when he goes to a general practitioner, usually he gets switched back to simvastatin, and we have to then double check and make sure that that is not something that remains, because then it can lead to important interactions. We usually, a lot of us prescribe atorvastatin. Pravastatin is also good, and then the most recent rosuvastatin seems to have a little bit less of interactions, but if he switched to dolutegravir, he could receive simvastatin. So the right answer is 4 and 5, probably. I will not go into too much detail, but if you want to keep the patient in albuterol covisistat, Rosuvastatin is probably the only one that does not have any absolutely significant interaction. You can, of course, treat him with atorvastatin, but you should be careful because if you decide to do that, because you have like budget limitations in your hospital or whatever, just start very slowly, right? And think about probably changing his antiretroviral drugs if he really needs these. An important point is that if he is on dolutegravir, he can receive simvastatin. So simvastatin is it's not prohibited. So there are a lot of our patients are gonna be able to use simvastatin in the future. The big problem comes with ritonavir boosted PIs and then NRTIs. Okay, so after 6 months on rosuvastatin, the total cholesterol gets better. His BMI index is still 32. You're good, but not that good. And then he begins metformin up to 850 milligrams BID. So the question is, which of these antiretroviral drugs interacts with metformin? And we have elvitegravir, cobicistat, tenofovir, dolutegravir, darunavir, and the one that's really very important to know is dolutegravir. So dolutegravir can increase the metformin Cmax and AUC significantly. If dolutegravir is given QD, the increases are shown here, 66 and 79% in both values. But if dolutegravir is given BID, the increases can be very, very significant. So if you have to prescribe metformin in a patient receiving dolutegravir for whatever reason, the US prescribing information suggests limiting the total daily dose to 1,000 milligrams, and you have to monitor the renal function before and after, as well as the blood glucose, because there are chances. So dolutegravir inhibits metformin, is eliminated through, you don't see it well here, but it's eliminated from blood. It gets through the tubular epithelial cell and is eliminated unchanged in the urine. And it gets through these two transporters, OCT2 and MATE1, and dolutegravir inhibits both of them. It is also important to note that cobicistat also inhibits MATE1. So there are a number of potential, probably non-clinically significant associations with cobicistat, but everything depends on which are the margins and where you are and which are the doses you're giving to your patients. So, okay, so his glycated hemoglobin becomes, so you do well, the glycated hemoglobin goes down. He has no adverse events, but he's still on tenofovir. His DEXA, you do a DEXA scan, his T-score is minus 2.7. So he has osteoporosis, right? And you want to prevent further fractures. So in terms of antiretroviral interventions, there are a number of antiretroviral interventions that can be made. One is to switch the patient to TAF. The other one is to switch him to an abacavir-containing regimen, for example, abacavir 3-TC dolutegravir. Some people have tried to switch to boosted PI monotherapy, but I think that the Eugenia's group will present some data afterwards about the PIs on bone. And the other option would be to stop ART. That's not an option, really, right? So you don't stop ART, and then do that. And nowadays, I don't think that there's any reason to go to boosted monotherapy. We can discuss about the dual therapies, of course. There's room for that, but that's still under discussion. So there you have two options. Eugenia's group has done research in the past and published very nice data showing that when you switch from tenofovir to abacavir, there are improvements in bone and bone density, but also a number of different studies have shown increases in bone mineral density after switches from tenofovir to TAF. I am not aware, and I might be just saying something completely wrong, maybe I should, but I'm not aware of strong direct comparisons between the two of these two strategies and to see which one is better, but maybe you guys can correct me. It's just, it's ongoing, right? So then I'm right. So if you decide to switch to TAF, think that in this patient, when tenofovir has some effect on the lipids, and you should not expect that from TAF. And that's because it is not clear what tenofovir does, why tenofovir decreases the lipids, but it is associated with having high levels of tenofovir in plasma. Characteristic of TAF is that most of the metabolite is inside the cell, and you should not expect any benefit on lipids from switching to TAF. Then reducing the risk of fractures, and this is a comprehensive effort that has to be seen, as Dr. Waraldi has said before, as within an integrated geriatric assessment. You need to, the EX guidelines recommend to aim for decreased falls by assessing fall risks, and this is a classical geriatric syndrome. We need to ensure sufficient dietary calcium and vitamin D. We need to screen for osteoporosis, and then think of different therapies, biphosphonate treatment. It is very important to note that most changes happening in the bone mineral density after starting treatment happen very early. So I think that it has been suggested that probably maybe there are interventions that could happen in the during the first year. So maybe you don't need to keep patients on biphosphonates forever, but maybe by doing it during the first year of therapy, that could provide a benefit. So, and that's it. I try to not to extend myself too much. So, early art is key. Smoking is central to accelerated aging and survival reductions in people living with HIV. We should definitely we spend a lot of money and time discussing about inflammation and other stuff, and not enough on smoking, and this is my Dr. Jekyll side. So we should beware interactions, statins and ritonavir, but also cobicistat. Simvastatin is okay sometimes, but you need to, now we have in our minds, some people have just banned simvastatin, but in certain environments it could be okay. Metformin, you need to be aware of the interaction between metformin and dolutegravir, but also with cobicistat, although in many cases this is of uncertain clinical significance. The second one. Prevention of bone mineral loss may involve switch from tenofovir to bacivir or TAF. There are no direct comparisons. We still don't know which strategy is better. TAF does not impact lipids. It's an excellent drug, but that's not what TAF does. And we need for comprehensive geriatric management. So thank you very much.